Good evening, everyone, and welcome to this evening's session of the Fellow Gecko meetings. The GECHO meetings is hosted by the Gastro Foundation in association with Project ECHO, University of Mexico. It runs every second Monday at 6 p.m. And yeah, if there are any questions during the presentations, you can post them in the chat. Then we'll try and get to them at the end of the presentation. For this evening, Dr. Yaaseen Sungay will be talking to us about acute ulcerative colitis. Yeah, over to you, Yaaseen. If
Uh,
people in the background can maybe switch off their videos if possible, and then yeah, maybe switch them on if they have questions later on in the presentation.
Thank you, Dr. Seabi. I just want to share my screen. Okay. Are you able to see my slides?
I think that now we can see here there was a slide
Okay.
delay.
Okay. Am I good to start?
Go
Yes, you can
ahead.
go ahead.
Yeah. Okay. Thank you to Project ECHO and GECHO for allowing me to participate in the Gastro Fellow presentation series. My name is Yaaseen Sungay. I'm a gastroenterology fellow at Tygerberg Hospital, and I will be presenting on acute severe ulcerative colitis. My supervisor for this talk is Dr. Seabi. So just a little bit of, sorry. There we go. Apologies. So just a little bit of background of IBD in sub-Saharan Africa. So in terms of the incidence of IBD in Western countries have increased and subsequently plateaued. Similar trend has been noted in Asia, North Africa, and South America. There's been an exponential increase in IBD over the past 70 years in South Africa. And apart from South Africa, I IBD in sub-Saharan Africa is considered really uncommon. Some cases of IBD might remain undetected in sub-Saharan Africa because of a lack of awareness, deficiencies in diagnostic and clinical capacity, and substantial rate of misdiagnosis due to high burden of infectious diseases. It affects all ethnic groups, with UC being more prevalent in the Black African groups. And having said all of that, there's still a paucity of data with regards to IBD in sub-Saharan Africa. Specifically for ulcerative colitis, the peak incidence is between the ages of 15 and 45, with left-sided colitis being the most frequent location. Disease extension occurs in about 10 to 30% of patients, and most patients have mild to moderate disease courses, with patients having the most active disease at diagnosis, thereafter having varying degrees of activity. The cumulative risk of relapse is about 70 to 80% at 10 years. For acute severe ulcerative colitis, 25% of patients with ulcerative colitis will have at least one episode of acute severe ulcerative colitis, and more than a quarter of patients that present with acute severe ulcerative colitis presents at the index presentation of UC. Each episode risks complications such as bowel perforation, hemorrhages, thromboembolic events, electrolyte disturbances, and has a colectomy rate of around 13%. Mortality is around 1%, with risk factors including colectomy, age over 50, and delay in management and surgery. In terms of the pathogenesis of acute severe ulcerative colitis, little is known. It's a dysregulated systemic immune response to commensal pathogens in genetically predisposed individuals, which highlights the intricate interplay between genetic susceptibility and immune dysfunction. Acute severe ulcerative colitis is a distinct ulcerative colitis flare. presentation characterized by bloody diarrhea and systemic inflammation. It was Sidney Truelove and Leslie Witz in the mid-1950s that identified that systemic inflammation to be a major driver for complications and mortality in UC. The scoring system is most applicable in extensive colitis, although it does have limitations in patients with limited colitis. And the scoring system has never been validated in clinical practice. So just to talk about the Truelove and Witz criteria, we currently use the modified Truelove-Witz criteria for severity of ulcerative colitis, and that is because of the addition of the CRP. For mild disease, patients often have bloody stool, less than 4 bloody stools a day with no real features of systemic toxicity. So pulse is less than 90, they're apyrexial, they have a HP of more than 11.5, and the ESR and CRP may be unremarkable. For patients with a moderate disease activity, they often have 4 to 6 stools a day with some features of systemic toxicity, such as a pulse rate that may be equal to 90, low-grade temperature of 37.8 or less, an anemia of HP of 10.5, and some elevation in the inflammatory markers, but not more than 30. Then looking at patients with severe acute severe ulcerative colitis, they often have more than 6 stools a day, and their heart rate may be more than 90, with a temperature of more than 37.8, HB of less than 10.5, and inflammatory markers, both ESR or CRP, of more than 30. And to make the diagnosis of acute severe ulcerative colitis, you need at least, well, more than 6 bloody stools per day and any one of the other criteria of systemic toxicity. Then part of management of patients with acute severe ulcerative colitis, what I've included here is the Oxford criteria for response of steroids, which is usually done on day 3. Often patients can be complete responders and have less than 3 stools per day. Incomplete responders, which is 3 to 8 stools per day and a CRP of less than 45. And non-responders, these are patients that have ongoing bloody stools of more than 8 a day, or 3 to 8 stools per day and a CRP of more than 45. Other things to look at is poor prognostic factors in patients with ulcerative colitis severity. And this is younger than 40 years at diagnosis, extensive colitis, severe endoscopic disease, that's a Mayo subscore of 3, and a UCEIS of more than 7. Hospitalized for colitis, a elevated CRP, a low serum albumin, and the greater the number of prognostic factors, the worse the prognosis as measured by the likelihood of colectomy. Severity factors of acute severe ulcerative colitis can include non-steroidal anti-inflammatory intake, which is associated, will have a frequent and early clinical relapse of quiescent disease, concomitant C. diff infections. So in hospitalized patients for IBD, the mortality rate is 4 times higher in the C. diff group. Patients that have a CMV, specifically in steroid refractory patients, 50% of colectomy in patients with CMV reactivation versus 15% in patients without CMV. Toxic megacolons, a small bowel distension, is associated with steroid failure, and venous thromboembolism is associated with longer lengths of stay in hospital, and time to colectomy, duration of in-hospitalization treatment associated with higher post-operative complications. Of course, you should have a differential diagnosis, and some of the key ones are, of course, your infectious colitides, specifically C. diff, CMV, and parasitic infections like amoebiasis and schistosomiasis, ischemic colitis, other inflammatory bowel diseases like Crohn's disease, and then medication-induced colitis such as nonsteroidal anti-inflammatories and immune checkpoint inhibitors. Then, in terms of the general principles of management of acute severe ulcerative colitis, you want to make a swift diagnosis to decrease colectomy rates, identify triggering factors, identify worsening factors, assessing endoscopic severity, imaging for abscesses or perforation, management of thromboembolism risk, mitigating surgery associated with morbidity and mortality, an early surgical consult and early referral to your stoma team, including a stoma sister, and then optimizing nutritional status. Decision making forms an integral part of management of patients with acute severe ulcerative colitis. This is a diagram that's a good overview of what to do when patients present with acute severe ulcerative colitis. We'll go into more detail of at each step. So on day one, you want to have baseline investigations, including a FBC, a UNE, electrolytes, and your inflammatory markers, including a CRP or ESAR. Stool, MCNS, and C. diff. You want a chest and abdominal X-ray, and if, you can get a CT scan, a CT abdomen. Venothromboembolism prophylaxis with enoxaparin is important. Endoscopic assessment. You want to assess disease extent and rule out CMV colitis, usually within 72 hours, but preferably within the first 24 hours. You want to withhold the 5 ASAs because it can paradoxically worsen diarrhea. Again, early surgical consult with daily review. And currently, there's no place for routine antibiotics in patients with acute severe ulcerative colitis. Other tests to consider is a TB quantiferon test, hepatitis B screening, and screening for venothromboembolism events. And then the mainstay of treatment on the first day is IVI steroids, high dose hydrocortisone, 100 milligrams 6 hourly for 3 to 5 days. And thereafter, you want to monitor response and you want to avoid non-steroidal anti-inflammatories, opioids, and drugs with anticholinergic side effects, specifically in practice, morphine, tramadol, and loperamide, which can be given to these patients by junior doctors or junior staff. And these medication may cause colonic dilatation and toxicity and have been associated with poor outcomes. In terms of imaging, so X-rays, you want a erect chest X-ray to look for free air under the diaphragm. Abdominal X-rays to look for loss of Haustra, thumb printing, or lead piping. Look for any features of megacolon. You can use the 369 rule, being 3 centimeters small bowel, 6 centimeters transverse colon, and 9 centimeters cecum. In terms of ultrasound, bowel ultrasound has been recently gaining interest among researchers and clinicians, and several reports have shown that bowel ultrasound parameters such as bowel wall thickness and Doppler parameters correlate with endoscopic disease activity and can accurately predict response to treatment. I think very important here is how comfortable the operator is and operator experience with intestinal ultrasound, and of course a CT scan if patient have microperforations or abscesses. This is a slide on thumb printing, and then we have an X-ray showing a megacolon with mucosal islands, and this is a featureless colon with thickened wall and classic lead piping. In terms of endoscopy, the goals of endoscopic evaluation is, of course, to confirm diagnosis if there is diagnostic uncertainty, and especially in patients that present at index presentation, establish severity of inflammation, and obtain biopsies for CMV colitis. A full colonoscopy is usually not necessary and is associated with high rates of colonic dilatation and perforation, and a flexible sigmoidoscopy with minimal insufflation is usually sufficient. In terms of your endoscopic scores, we use the Mayo score, and just going through it in more detail. So it's divided into a score of 0, 1, 2, or 3. So a Mayo score of 0, you're going to have a normal looking bowel, pink with good normal vascular pattern. A Mayo score of 1 for mild disease, you'll have some erythema, decreased vascular pattern because of edema, mild friability. A Mayo score of 2, moderate disease, you've got marked erythema, absent vascular pattern, and friability with some erosions. And then a Mayo endoscopic score of 3, which shows spontaneous bleeding and ulcerations and very friable mucosa. In terms of the Mayo score, it's part of a much larger score, which includes stool frequency, rectal bleeding, and a physician's global assessment. Each factor gets gets a allocated number, and then you can you can determine the severity depending on how much the patient scores, um, being in remission, mild, moderate, or severe. Then just to look at the Montreal classification in terms of extent and severity. So extent, for patients with ulcerative colitis, E1 being ulcerative proctitis, which is involvement only of the rectum, E2, which is left-sided disease distal to the splenic flexure, and E3, which is an extensive colitis extending beyond the splenic flexure. In terms of severity, it also divides up into patients that's in remission, mild, moderate, and severe, looking at the stool count and features of systemic toxicity. The ulcerative colitis endoscopic index of severity is another scoring system that can be used, looking at the vascular pattern, bleeding, erosions, and ulcers. And compared to the Mayo score, which can be easily applied, the UCIS strengths are being objective and its prognostic value as well. Then on day 2 and day 3 of management of patients with acute severe ulcerative colitis, you have a daily symptom review. You want to know the stool count, any rectal bleeding, any pain or tenderness. And very important in patients with acute severe ulcerative colitis, that abdominal pain is a marker of instability. And these patients should be expedited to get imaging or have the surgeon review the patient immediately. Of course, perform abdominal x-rays guided by symptoms and early surgical consult. Then on day 3, call this decision day. And day 3, we try to decide on whether the patient is steroid responsive or not. And we use the Oxford criteria. If the patient is steroid responsive, you can continue IVI steroids for three to 5 additional days before switching to oral steroids, and then also to consider steroid sparing therapy. Then just coming back to our overview of management of acute severe ulcerative colitis. So of course, if patients are complete responders with a stool frequency of less than 3, they can be switched to oral steroids and then consider steroid sparing therapy, which we'll go through first. And then the incomplete responders or non-responders, they would then qualify for medical rescue therapy or colectomy. So the maintenance therapy for inpatients that responded to their high-dose hydrocortisone, you want to start oral prednisone 1 milligram per kg up to a maximum of 60 milligrams, and then consider steroid-sparing therapy So in the optimal long-term maintenance therapy for immune modulator naive patients remains unclear. There's a multi-center retrospective study in Italy that shows there's no difference between aminosalicylates and immune modulators and infliximab in immune modulator naive patients. And decision should be based on case-to-case basis, previous exposures, and depth of response to steroids. Patients that are hydrocortisone or steroid non-responders, it's very important to risk stratify patients, and that's very important in acute severe UC management. It helps to determine the need for early rescue therapy, guide timely decision for colectomy, and critical step to improve outcomes and reduce complications. There are multiple prognostic scores for steroid failure. Of course, we've discussed already the Oxford criteria, which has a colectomy rate of 85% if one criteria is present. And we have Lindgren, which looks at the stool frequency per day, and then you add a constant of 0.14 times the CRP, and if the score is more than 8, there's a 72% chance of colectomy. Ho et al. Uses a mean stool number on the first 3 days, albumin of less than 30 on admission, and colonic dilatation of more than 5.5 on X-ray. And that shows an 85% chance of steroid failure when they score more than 4. And in Gibson, a simple score of 3 stools per day and a CRP albumin ratio on day 3. And then Adams, albumin of less than 25, CRP of more than 100, and a UCEIS score of more than 4 on day 3 or more than 7 on admission. Shows an 84% chance of steroid failure when they score more or equal to 3. This was a study done at the University of Alexandria in Egypt, looking at the evaluation of predictors for steroid therapy refractoriness, and they found that a lower albumin and oral steroids prior to admission for acute severe ulcerative colitis are predictors for IVI steroid failure. And they said that these patients should be earmarked for early rescue therapy or colectomy. In terms of rescue therapy management in patients that are steroid non-responders, I mean, up to a third of patients are steroid non-responders. So quite a large proportion of patients can be steroid non-responders. And medical rescue therapy can include infliximab and cyclosporin, tacrolimus and tafasitamab, which we'll talk as an up-and-coming treatment. Infliximab rescue therapy has been increasingly preferred over cyclosporin or calcineurin inhibitors due to better side effect profile, availability for maintenance therapy, induction doses of 5 milligrams per kg at 0, 2, and 6 weeks. And efficacy reports short-term response rates can vary widely from 0 to 100%. Long-term colectomy-free rates 41 to 81% after rescue therapy for acute severe UC. Infliximab and cyclosporin have comparable short-term and long-term outcomes. And infliximab is often preferred in clinical practice. Patients that don't respond to infliximab rescue therapy often have a high TNF burden. They have proteolytic degradation of anti-TNF and associated with a higher or increased drug clearance. Fecal loss from increased gut permeability associated with severe inflammation. And to overcome these factors and achieve successful induction of remission, accelerating infliximab dosing can be considered for patients with acute severe ulcerative colitis. However, the overall data from retrospective studies does not show superiority for accelerated infliximab dosing, perhaps in a select group of patients with low albumin. In terms of the use of cyclosporin, in the past, cyclosporin was the primary treatment for acute severe ulcerative colitis and a bridge to immune modulators such as azathioprine. More recent studies show its efficacy of cyclosporin as a bridge to Vido and ustekinumab at a dose of 2 milligrams per kg per day. It's a bit more involved in terms of administrating to the patient. You need to do drug level monitorings, often require a high care setting with cardiac and electrolyte monitoring, and side effects can include nephrotoxicity, elevated blood pressures, seizures, anaphylaxis, and sepsis. And then remission achieved with cyclosporin. Maintenance therapy can be used, which can be used as thiopurine or vedolizumab. Tacrolimus, it is not commonly used as far as I'm aware, but it's good to know that it's part of the arsenal in terms of treatment of patients with acute severe ulcerative colitis. It's also a calcineurin inhibitor with good oral bioavailability. The oral dose, initial dose is 0.1 to 0.15 milligrams per kg per day. The IV dose is 0.015 milligrams per kg per day. You want a trough target of 10 to 15 nanograms per mole during induction until complete remission, and side effect profile is similar to cyclosporin. The short-term efficacy for refractory UC is around 70%, and prognosis shows that it's effective for induction, but long-term outcomes remain suboptimal. In terms of tafasitamab, it's an emerging therapy for acute severe ulcerative colitis. It's orally taken and it's a rapidly acting pan-JAK inhibitor, which is approved for the use of in UC. Potential benefit due to its fast onset of action. Initially, there was safety concerns due to thromboembolic events in cancer patients, but the initial data was in rheumatoid arthritis patients that were older than 50 with cardiovascular risk factors. However, safety data in the IBD population is reassuring. So it's a promising therapy for acute severe ulcerative colitis, and especially for young patients without cardiovascular risk factors. An aggressive strategy was proposed with IVI steroids and a tofacitinib dose of 10 milligrams 3 times a day from admission. There was a TRIUMPH study that came out earlier this year, which is a prospective open-label interventional trial of tofacitinib in hospitalized patients with acute severe UC, conducted at 5 hospitals across Canada. Shows that tofacitinib is an effective rescue therapy in hospitalized patients with steroid refractory acute severe ulcerative colitis. However, randomized controlled trials are warranted to compare the JAK inhibitors with other rescue therapies, including infliximab in steroid refractory UC. Other medications, just to mention, is filgotinib and upadacitinib. They are potential options for acute severe UC, quick onset of action, but currently no recommendations for acute severe ulcerative colitis. So other factors to consider in patients that don't respond is a C. diff infections, which you treat with either vancomycin and or fidaxomicin, which is incredibly expensive. CMV infections. So if patients are steroid refractory, you want to check your immunohistochemistry and mucosal PCR to see if they're CMV positive. If a patient has responded to induction therapy and the CMV tests are positive, there's no need for treatment. If they are non-responders and the CMV is positive, then you want to treat CMV with ganciclovir 5 milligrams per kg uh, for 3 to 5 days, and then switching to oral valganciclovir 900 milligrams BD. And of course, if they have severe systemic CMV, you want to stop immunosuppressive therapy altogether. In terms of sequential therapy, the benefit outweighs the risk, and it should only be done at expert IBD centers. Conflicting data leads to not recommend second salvage therapy as it delays time to colectomy. Um, in terms of nutrition, the debate is always enteral versus IV nutrition, which is better for the management of acute severe ulcerative colitis. Currently, there's no difference in colectomy rates or mortality in patients that had acute severe ulcerative colitis receiving high-dose IVI steroids on bowel rest with parenteral nutrition and those with the oral diet. In terms of indications for colectomy, patients that do not respond to rescue therapy, patients that have intestinal perforation, massive hemorrhage, toxic dilatation with impeding perforation, and long-standing colitis with intractability would all be indications for colectomy. Just a little bit of surgical management for ulcerative colitis. As you can see, there are multiple approaches in terms of the staging. You can have 1, 2, or modified 2-stage and 3-stage, which is the more traditional procedure, which is a subtotal colectomy and endoileostomy. During the first procedure, the second procedure, the J pouch and ileal pouch, anal anastomosis, and diverting loop ileostomy, the second procedure, and then the ileostomy closure as the third procedure. Then after after total proctocolectomy for medically refractory UC, ileal pouch anal anastomosis is the procedure of choice, but permanent ileostomy is also a reasonable option for some patients. Ileal pouch anastomosis can, like I said, be done as either a 2 or 3-stage procedure, and it can either be done as a stapled or hand-sewn technique with comparable functional outcomes. UC patients with mild rectal disease may undergo ileorectal anastomosis, and just looking at the different types in terms of illustration. You can have the J pouch and S pouch. I think there's also a W pouch that can be done. The first procedure is usually a colon and rectum removal, then a temporary ileostomy and a J pouch. And then you want to close the ileostomy and you have an ileal reservoir. In terms of predictors of poor surgical outcomes, of course, increase in age, a low albumin, patients with multiple comorbidities, prolonged steroid use, infections. In terms of infliximab use and post-operative complications, infliximab was not associated with an increased risk of 30-day post-operative complications. It's put down more to steroid use. And then just in summary, so management of patients with acute severe ulcerative colitis, general principles on admission, on your stool cultures, your basic bloods, imaging, endoscopic score, endoscopic assessment, thromboprophylaxis, and then no systemic use for antibiotics. First line treatment is high dose IVI corticosteroids in the form of hydrocortisone. And then you want to evaluate the patient on day 3, primarily using the Oxford criteria. If the patient has not responded and they anti-TNF naive, you want to use either infliximab or cyclosporin. Of course, if they're anti-TNF exposed, then you can use cyclosporin as a bridge to Vedo or ustekinumab. And then you have also tofacitinib as an upcoming therapy. At each stage, and then a third line is colectomy is recommended, and then a third line medical therapy only at expert centers. If you use infliximab first, then cyclosporin, or vice versa, or even tofacitinib. At each stage, you need to consider surgery should the patient decompensate. Um, yeah, thank you.
Thank you, Yassine. I haven't seen any questions from the chat. Does anyone have questions? Yeah. Yeah, I think it was quite thorough. It's a short topic. You were lucky this time, because sometimes people are given huge topics to
Is
cover.
it?
But I think it's nice and concise, and people will hopefully pay attention. Um, so tell me if somebody flares on infliximab, because there are many people now on infliximab as just their routine therapy. What's the data there for rescue therapy with other
So,
medications?
so it seems that in patients that are on infliximab as part of their maintenance therapy, you'd probably want to use cyclosporin as a rescue therapy, as a bridge to either a different agent, because like Vedo or ustekinumab, but that does come with, specifically in the state sector, come with pricing and and expense issues. But yeah, as far as I'm aware, if the patient has failed a biologic and has fled on infliximab or anti-TNF, then you'd want to use cyclosporin. There is emerging, I mean, in terms of using tofacitinib, it's not widely recommended, but that may be an option going into the future, and also with tofacitinib maybe becoming more affordable, might become more common in clinical practice.
Yeah, so because I think a lot of people are anxious about using cyclosporin, which for most of us in the state sector is what is available, but there is some data, although not a lot, about using cyclosporin in patients who have acute severe colitis on infliximab. I think, the clinician would have to take the necessary precautionary measures. And yeah, Pascal, on the chat, I mean, he did mention about the role of accelerated therapy. I don't know if maybe you want to know exactly how accelerated it would be versus standard, but he did explain how patients with acute severe can fail infliximab rescue therapy because of high disease burden and the activity against the antibody, but he did mention it. So what I've done in practice is I would give sort of like half the recommended, it's 0, 0 to 6. So I'd give 0, and then after 1 week, and then after about 2 to 3 weeks. So that's how I've done accelerated dosing with good response. Otherwise, it would just be 0 to 6. Alternatively, some people give a double dose on that first infusion, so 10 milligrams per kg. But that would be based on, your assessment of the patient at the time. But I looked before and I couldn't find like a specified a regimen for this accelerated regimen, and that's the one that I've used, 01, 2 to 3 weeks. VG, there was a
Sorry, yeah, I was going to ask something else, but when you're talking about an accelerated regimen, you're talking about infliximab that you were
yes,
referring to. There.
yeah,
Oh,
yeah.
okay. So
Mm.
while I was getting confused between
Yes.
cyclosporin and infliximab with
Sorry, I
the.
quickly moved to the chat. Hey, I'm multitasking. The questions on the
Yeah,
chat.
sorry.
Yeah.
Yeah, no, that was very nice. I think the only thing I wanted to ask about is firstly cyclosporin. I remember years ago we tried to order it for somebody, and they said they should be able to acquire IV cyclosporin in about a week. So it arrives a week later, which is completely unhelpful. Hopefully, I really don't know how much experience anyone has with accessing IV cyclosporin urgently. Um, Certainly, we tried,
Yeah.
and yeah, I think we'd rather do it, colectomy. The other question was about CMV. Now, we all you recommend that as soon as you establish the patient has acute severe ulcerative like colitis, one of the things you should immediately do is a quick look, limited sigmoid, and I usually use a upper scope because these are very fragile, like colons, and I hardly any air, if virtually none. Use the upper scope, and you don't have to really go far up the sigmoid. Just beyond the rectum is more than enough, and you know exactly now that you are dealing with uh, acute severe ulcerative
Yes.
colitis. Sometimes a patient with just severe rectal inflammation, severe proctitis, can complain like you wouldn't actually believe. You really believe the patient has acute severe ulcerative colitis, but it's just that end, little bit that's inflamed, which is why we rely on all those other true love and fits criteria. And the reasoning behind having those true love and wits criteria, which have stood the
Yes, of time.
test of time, is that they work. So it isn't about how you feel this patient. Maybe they're not so bad. If you should just stick to the Trulabin-Witz criteria and treat as acute severe ulcerative colitis. Don't try and go outside of them. So ulcerative colitis, acute severe ulcerative colitis, is fairly standardized in terms of how you make the diagnosis and the sort of management. Okay, now quickly returning to the CMV issue. So we recommend, okay, you go in as early as you can, if not a few hours or early the next day. Do this thing and take the histology. Now, I don't know, in your presentation somewhere you were saying you can wait for 72 hours and then
No,
check if the patient's responding, and then you find the CMV. We would usually recommend here, although it isn't easy all the like in time, is that those biopsies should be processed urgently, and you should have an answer within a day. And if the patient has CMV and you've already started the steroids and all of that there, then it's recommended the patient gets antivirals like ganciclovir. So I was a bit confused about where you're
well,
saying you could hold on for 72 hours, and then if the patient's
Yeah.
responding, then you can think about it. But if they're not responding, can you just sort of clear it up a little bit there?
Yes, yes, yes. So essentially, well, what I initially said was you want to do a flexible sigmoidoscopy within 24 hours. Well, within 72 hours, but preferably in the first 24 hours. Um, and
Okay,
then
I think over there is the
I think that's
first
where the
area I need
confusion was in.
to
So you wanted,
I need to start there, because in acute severe ulcerative like colitis, 72 hours is a long time.
it is a long time.
You already
Uh,
got 3 days of hydrocortisone, and then the surgeon's already sharpening his knife there. Yeah.
yes,
But
yes.
he's saying at
Um,
least ideally within 24 hours, if possible. I think,
Okay.
in some instances, you may
yeah.
not easily have access to an endoscopy suite or theater, or an endoscope.
Yeah, if
But
you have your
ideally,
endoscope, I think you
mm,
can perform it anytime.
mm,
Yeah, and you shouldn't have to hold on for a room even. You're just going to have a quick limited. I mean, in the old days, we had your rigid sigmoid that we could use in the like rooms.
mm.
Okay, I ain't so old because it's not. Okay, so I think we must all agree that it should be done as early as possible, and 72 hours might be a
Yes,
bit long in terms of
on the
making
long
a
side.
treatment decision, because you also need to give the people in the lab an opportunity to stain and do the immunohisto like in
Chemistry.
chemistry,
Yeah.
which they can do if you ask them within a few hours actually. And
Mm.
then CMV, if you do find it, Neo, or how do you do with it?
We generally treat especially, in acute severe, it's difficult to know for sure whether you're dealing with
What happens if you've started the patient on some steroids, and 72 hours, and you receive the result from the lab, but now the
still treat.
CRP is now 18 from 100, and the stool frequency is now 2 or 3. So it looks like everything's improving, and then you receive this CMV result that say, we've seen some CMV.
I think he
That
did
was just
mention
interesting. I
uh,
have no
So,
answer myself.
so what I read is that essentially in those patients you can continue with treating acute severe
steroid.
UC. Yeah,
Because it can be like an innocent
Innocent
bystander.
bystander, yeah.
So you have to make your decision based on how the patient is improving or not, and whether the patient's improving.
Okay.
Okay.
And
Ian
then
Lang is asking if anybody has experience with using adalimumab as second-line therapy in facilities with issues with access to infliximab. Unsure, if not recommended due to lack of evidence. Okay, so it's not mentioned anywhere in the treatment of acute severe colitis, as far as I know. Did you read differently, Yassine?
yeah. No, I agree with you. I haven't seen anything specifically with adalimumab. All the literature that
Mm.
I've read is infliximab or cyclosporin.
so regarding adalimumab for acute severe colitis, it isn't approved for its use. So the only anti-tumor necrosis factor alpha agent that is approved in acute severe ulcerative colitis for your rescue therapy is infliximab.
So,
Right.
Yassine,
Yeah.
if acute severe colitis is complicated by C. diff, should the rescue therapy be withheld until infection clearance?
So no, I mean I don't think so, but you can correct me if I'm wrong. I think you should treat the C. diff and then continue with the rescue therapy as
Yes, you
well.
treat both of them. And then, does the presence of C. diff in acute severe UC justify prioritizing surgery over medical rescue?
Hmm.
I think maybe it's
Hi.
because you mentioned it as, did you mention it as one of the risk factors for,
For
I think if
non-response,
the
yeah.
if the C. diff RAMA is also associated with maybe toxic megacolon. I mean, if there is a real reason to do colectomy, then you can prioritize that. But this is something that can be easily treated, without subjecting the patient to colectomy. Okay. So Yaaseen, so
Yeah.
let's say you've treated your patient with IV cyclosporin. How do you change over to oral? And then also, how do you manage concurrent immune suppression in those patients?
Um, in terms of the specifics, I'll be honest, I'm not sure because I haven't had much experience with cyclosporin in patients with acute severe ulcerative colitis. Um, yeah, maybe you can enlighten me.
Mm. Okay. Yeah. So, I mean, we also don't use it a lot, but we have used it in some patients. So, as you said, the IV dose is 2 milligrams per kg
KG, yeah.
per day.
Mhm.
So that infusion has to run over 24 hours. And when you give cyclosporin, you have to do certain baseline bloods because for instance you can't give it in hypomagnesiemic patients. You have to correct that. You have to check that they're not hypocholesterolemic. So there's certain contraindications for giving a cyclosporin infusion. And so because you give that infusion for about 3 days, and then you'd assess for response or not. But if the patient responds, then you can't just stop it. So you have to go on to oral,
Mm.
which is, if I remember well, 5 milligrams per kg.
Okay.
And you have to give that and also start the immune suppressant that you're going to use in the long term. And I remember we had an elderly lady that it was a very difficult decision to make because this is somebody who'd fled, and it's probably somebody who's going to need more than just uh, 5 ASAs.
Pfizer, yeah.
So we had her on the 5 milligrams per kg oral dose, and then we had to give her azathioprine. Yes, elderly, I know, lymphomas and all, but I mean,
Yeah.
that's azathioprine works for UC.
Mhm.
You have to watch them quite closely because you're giving them double immune suppression. You have to give
Yeah.
them PJP prophylaxis. Mm, yeah, but
Mon
the this is that the cyclosporin at some point, so because you can't give it beyond a certain point. So that particular lady, we gave her for 3 months a combination, and then eventually she was just on the
is
azathioprine,
it?
and
Okay.
luckily she never flared again. But there is something about changing over from IV to oral cyclosporin, in just an uncomfortable period where you have to give the patient quite a lot of immune suppress immune suppression, and you have to watch their counts frequently,
Yes.
yeah, during that whole process. But in my experience, it has worked. And one patient was quite close to colectomy. That she was a young lady, but now she still has a colon in, but it's proper scarred. Like she has got significant scarring, and she's even got diarrhea, and we think she's probably not even absorbing water well from
Mm.
the colon because it's so scarred.
Mm.
What else did I want to say? Um, yeah, just also with regards to the pouch in patients who don't have a pouch, but they have an ileorectal anastomosis, that a remaining rectum still has to be under surveillance because they can still
Yeah.
have
Yeah,
disease
of course.
there or dysplasia. Mm,
Yeah,
yeah, maybe.
maybe I can ask Yassine a question. Yassine, why should low molecular weight heparin actually work beyond this thing about prophylaxis for your deep vein thrombosis? why should it improve ulcerative? I mean, it seems like the opposite thing you want to do if someone's having a GI bleed, isn't it?
Yeah, no. As far as I'm aware, acute severe ulcerative colitis is a pro-inflammatory state. Of course, that comes with thromboembolic events because of inflammation in the body. In terms of its ability to help treat ulcerative colitis, I'm not sure, Dr. Naidu. Um, but
Yeah,
in
it's
terms
yeah,
of its
yeah.
use in acute,
No, that's actually excellent because there is an effect on the. You are correct about the anti-inflammatory response, and especially on the effect on the your large bowel itself, and ischemia at that level, at the microvenous level. So ulcerative colitis is actually acute severe ulcerative colitis. There's also ischemia and inflammation, and the low molecular weight heparin. Other than the evidence from the trials and all of that there that it improves, there is a biological explanation as to how it may help. Because we often get we're a your referral hospital, so often we'll receive a phone call from one of our regional hospitals, and plenty of them are horrified that we would say start the patient on low molecular weight heparin. They say, but this patient's bleeding. Like it's the
wow,
most counterintuitive thing for a physician to
yeah.
say you're going to put somebody who's got a GI bleed on low molecular weight heparin.
100%. I mean, it seems very counterintuitive, especially when speaking to, uh, medical officers or surgeons. It does seem counterintuitive, but of course, experience and in the literature it's shown to be
Yeah,
beneficial.
but it's also worthwhile to return to the original science and see how it actually works. There was some interesting
Okay.
studies on both humans and mice
Mm.
as well. Yeah, that's all I actually wanted to say. I think someone else, Neo, is asking something in the your chat there.
Yeah, Ibrahim, any association between flare or number of flares and colorectal risk?
Um, so
Colorectal
it's
cancer.
yeah. Um, I don't know the data, or I haven't looked at the data myself specifically for this, but it seems like more inflammation may lead to more dysplasia and metaplasia. So in my head, it seems like it may increase the risk, but I'm not sure. I'll have to go have a look at what the data says.
Yeah, so it's not really flares, it's ongoing inflammation that
Mm.
increases the risk of dysplasia and colorectal cancer. So you may have mild to moderately inflamed disease without any episodes of flaring, but you'll still have a risk of dysplasia. So as long as there's inflammation, there's a risk of dysplasia and colorectal cancer. Okay, I think, yeah, if there aren't any more questions, I'm going to bring the session to the close. I'm not seeing any other questions. All right, so yeah, thank you, Yassine, again for this broad overview. And thanks to ECHO, University of Mexico, and ECHO India team for the support as always. All these recordings for all these talks will be available on the Gastro Foundation website. And thank you also to the Gastro Foundation for keeping this program going. The next session will be on Monday, the 22nd of September, 6 p.m. And the topic then would be pouchitis, presented by Dr. Jack Turiahikayo, and the chairman will be Dr. Viji Naidu.
Oh, oh, it's me.
Yeah.
Oh, okay. I better speak to that.
Yeah.
Thanks.
All right, then. Thank you, everyone. Good night.
Thank you so much. Keep well.
Okay, bye.
Evening, everyone. Thanks.
Evening.